Hello friends, now I'll be continuing with the topic of mitral stenosis. In my previous lecture I covered about the pathophysiology of mitral stenosis, symptoms and what we get on examination. So today I'll continue with the part 2 of mitral stenosis. First of all, I'll be talking to you about the investigation for a case of mitral stenosis. Investigations. First is ECG. Okay. In ECG, what we get? We may get P mitral. That means wide P wave. Wide P wave. What do you mean by wide P wave? Let me tell you the basic concept about P wave. Normal P wave is height and width both are less than 2.5 small square in ECG. I hope you know about the ECG paper. So in the ECG paper, when you look at a P wave, height and width both are less than 2.5 small square. But if the width is more than 2.5 small square, we call as P mitral, that indicate left atrial enlargement. So this was regarding basic concept about P mitral in ECG. You are getting a wide P wave. Well, in the very advanced stages of mitral stenosis, when even right atrial may be enlarged, but that P wave is more than 2.5 small square. This is known as P pulmonale. That indicate right atrial enlargement. So to begin with, you get only P mitral. Later on, you may get P pulmonale, but you get only in the very advanced stages. So ECG, what we get is P mitral. Number 2, we may also get atrial fibrillation on ECG. There is no P wave, and if the atrial fibrillation occurs, then there may be rapid ventricular rate also. Ventricular rate may be rapid. Third, there may be feature of right ventricle hypertrophy and right axis deviation. So friend, ECG is P mitral, atrial fibrillation, right ventricle hypertrophy and right axis deviation. Now, what do you get in Xray? Xray, in a case of advanced case of mitral stenosis, chest Xray. First of all, we get straightening, straight of right, straightening of the left border is the first finding. It's the earliest finding of a case of mitral stenosis. Later on, you may get enlarged left atrium. You may get prominent upper lobe veins, so-called coronal mustache sign. That is, in the upper lobe of chest, the venous marking is very prominent. Fourth, there may be Curly's B line. Okay, these are the chest X-ray finding in a case of mitral stenosis. Now, what is the most accurate test? Is echo. This is the most accurate test. In this you can see the valve area. You can see valve calcification. You can also see flow of blood from LA to LV. You can measure ejection fraction. How much is the ejection fraction? All these we can see in echocardiography. Okay, and there is okay. This is all what we get in echocardiography. So now we talk about treatment of case of mitral stenosis. Treatment. Suppose patient is asymptomatic. There's no symptom. And patient is just diagnosed incidentally by echocardiography or any other way. Patient has no problem. Then no treatment needed. Just do follow-up. You tell the patient to come to you every 2 months, or you tell if you have any problem, come and consult me. Otherwise, no specific treatment. Otherwise, as I told you yesterday, that the first symptom or initial symptom of MS is dyspnea on exertion. If patient has dyspnea on exertion, then you give diuretics. Usually we prefer to give loop diuretics. Okay, and it is how it's going to act. It's going to decongest the lung. And that's what we want. Once the lungs are decongested, patient will have tremendous symptomatic improvement. But if patient is not being controlled by diuretics, or patient develop atrial fibrillation, then you should add digoxin, especially if patient has developed atrial fibrillation. Now, what is the reason of using digoxin in atrial fibrillation? For that, we learn the basic concept that why we want to use digoxin in AF. Here is the basic concept of pharmacology of digoxin therapy. Here is the heart. Here is the AV node. Here is the AV node. This is a bundle of his Purkinje fiber. Normally impulse comes from SA node. This is SA node. This is AV node. Impulse come and the normal contraction of the heart occurs. But as we know in AF, impulse come from all the places. About 500 to 600 impulse, they come to AV node. 500 to 600 impulse coming to AV node. Point to note it very carefully. And we also know that AV node has the longest refractory period. AV node has got longest refractory period. Suppose 600 impulse have come here. It will slow down. Maybe only 150 impulse will go down, because 450 impulse are stopped at AV node only. This is normal I'm talking about. So now, so still ventricle rate is very high. 150 is very high. So patient has got very fast beating heart. That's why when AF start, due to very rapid ventricle rate, patient start complaining of palpitation. Palpitation. So once a MS patient start complaining of palpitation, it's quite possible that patient has developed atrial fibrillation. When we use digoxin, it further increases refractory period of AV node. That means the amount of pulse coming down may be 100. From 150, the amount of impulses going down to ventricle is maybe around 100. Okay, the ventricle rate is slowed down. Remember, the primary aim of digoxin is to slow down the ventricle rate. Okay, of course, our other aim is to convert AF into normal sinus rhythm, but normally in MS patient, ventricle atrial size is very, very large, so it's usually not able to convert fibrillation into normal sinus rhythm. So now you understand why we added digoxin in case of atrial fibrillation. Well, you start treating the patient, and of course, one big problem with AF is thrombus formation, which I discussed yesterday also. So if a clot develops, then you may add warfarin. Normally, traditionally, with no clot formation, you don't need to add any warfarin. So in nutshell, the main treatment, medical treatment, is diuretic, and digoxin we add only when the patient has got atrial fibrillation. Well, you are giving this drug to patient still not responding. Then we think about doing surgery. First of all, let me say what are the indication of surgery. Before that, we should know what are the criteria of severe MS. Criteria of severe MS. Longer the murmur, more severe is mitral stenosis. Number 2, this is opening snap. This is A2. A2 is the second sound. Closer the opening snap to A2, more severe is mitral stenosis. There are 2 criteria of severe mitral stenosis. But remember, patient may have severe MS, but he may be totally asymptomatic. Point 2, noted very carefully, I'm repeating second time. Patient may have severe MS, but patient may not have any symptom. So severity does not go well with the symptom of patient. Okay. Well, now suppose patient has severe MS and he has his symptoms are not being controlled by therapy. Then we start thinking of surgery. Now, what are the indications of doing surgery in MS? Indication of doing surgery. First of all, patient has severe symptoms. That means he has grade 3 or grade 4 dyspnea on exertion, despite adequate medical therapy. What do you mean by grade 3 dyspnea on exertion? Patient says, I feel breathlessness only on doing my activity or daily life, like taking bath, eating food, going to toilet. This is grade 3 dyspnea. Grade 4 dyspnea, when the patient has dyspnea at rest. If these are things not being controlled by medication, you plan for surgery. Second indication is patient has recurrent thromboembolic phenomena. There are 2 indications of surgery. Now, what type of surgeries we can do? The surgery what we can do is valvotomy. Number 1 is valvotomy. Other is valve replacement. Valvotomy and valve replacement. So first we learn the basic concept about valvotomy. What is valvotomy and how it is done? So here is the mitral valve and here is the valve. And valve is not calcified. Well, what we done, if valve is not calcified, and number two, there is only pure MS, only pure MS. Okay, there is no MR. Pure MS means there is no MR, only MS is there, and valve is not calcified. Now in valve, what they do, they simple put a forceps and they just expand the forceps. Now all the fibers, they are broken down. They're simply dilating the. It is just like in urethral structure where they pass a bougie and they tend to dilate it. Same thing, they try to dilate the valve, but provided, again repeating second time, it should not be calcified and there should not be any mitral regurgitation. Valvotomy is done. Okay. Now we go for valve replacement. When we go for valve replacement, you change the valve, you put some other valve. Valve replacement is done if patient has MS plus MR. Then you have to go for valve replacement, or the valve is calcified. For valve replacement. Now, when we are replacing the valve, that means you are putting some new valve into the place of original one. So what type of valves we have? We have two types of valves. Two types of valves. One is tissue valve, and other is metallic valve. Metallic valve itself has got a lot of complication, pregnancy related problem. So if already lady has conceived and we cannot put the patient on warfarin, or if you have a young lady who has yet to get married, or even a married lady is there where family not completed, you like to use only tissue valve, because we don't want later on the lady will conceive and later have a lot of problem with warfarin. That's why we use tissue valve in these two. Third is elderly person. Suppose a patient has elderly man, he has MS. We don't want to give oral anticoagulant to elderly people, because oral anticoagulant itself has got a lot of problem in elderly people. Now, where will we use metallic valve? Remember, in tissue valve, the biggest disadvantage is 6 to 7 years is the lifespan. You have to change the valve after 7 years. But in all other cases, so in all young males, or the ladies where family has been completed, you like to use metallic valve, because lifespan is about 14 to 15 years. You have to again change the valve after 15 years. But remember, this advantage is lifelong oral anticoagulation. So I hope now you are clear about it, where we use valve replacement, and in valve also, in where we like to use tissue valve and where you like to use metallic valve. Now, what complication can occur in case of mitral stenosis? The complication of mitral stenosis are, first of all, complication of it can lead to pulmonary arterial hypertension. Number two, it can lead to hoarseness of voice, so-called Ottoner syndrome. This is due to enlarged left atria compressing the recurrent laryngeal nerve. Patient may have dysphagia. This is again enlarged LA compressing the esophagus. It can lead to endocarditis, is a big problem. And of course, if patient has atrial fibrillation, it can lead to thromboembolic phenomena. And remember, this embolism can occur both in systemic circulation as well as pulmonary circulation, because clot may form either in LA or RA. Clot may form in both the atria in mitral stenosis. So I hope you are clear about the entire pathophysiology, causes, symptom, investigation and treatment about mitral stenosis. Well friends, I have been doing these Facebook classes. I have a lot of previous lecture recorded which are there in YouTube. You can see. Now as exams are coming, entrance exam NEET has been declared on 7th January 2018, and I got lot of requests that I should discuss now total MCQ based questions. So now I'll be now onward from tomorrow itself, I'll be discussing about last minute revision points. I've been sending all these to the students who have joined me in my WhatsApp group. Those who have not joined, you can join me by sending your detail at 99682888832. Send me your name, your college of MBBS, city in which your college is there, your email ID, which year you are, or intern or post-intern, and have you joined our classes? If yes, then which city you joined our classes. Those who have not joined our classes, they can also send me. It's open for everyone. So once you join me, I'll be sending you a lot of other information also. So you can send it to this number. Now, what I'll be doing in the last minute revision point, they are the highlights, important points. I'll be discussing each and every last minute revision point, and I assure you, by the time you go for your NEET exam, I will be discussing 72% question of medicine will be coming based on these points only. You'll find the question what you are getting in your exam are what we have learned from me in the last minute revision point. That means a medicine constitute about 15 to 18% of the entire paper of PG entrance exam. So I'll be doing bit by bit daily information. You will keep on getting in your Facebook, and if you join me on WhatsApp also, we'll keep on sending information, and it's an open group, anybody can join, and of course idea is to prepare entire medicine and allied subject also I like to cover. So my idea is to cover at least 20% of the question what you will getting in NEET exam should be from what you are reading, you shall be reading in the next 2 months or 2 or 3 months. Thank you very much for watching this video. Please do give the feedback, how did you like it, and do join for last minute revision point. Tell your friend also to join it by sending me that information as given to you. Thanks once again. See you tomorrow 4:15 p.m. with the last minute revision point on endocrine. To start with, I'll talk about diabetes. Thank you very much.